Good afternoon, everyone. Thank you again for following us on the Last Visit First podcast. Today, we have two special guests. Very proud to bring Scott Tapp, the CEO of Trella Health, back with me. Scott and I had a really good episode and got lots of views and lots of people watched it. And we got lots of feedback around that one. So we're going to do this quarterly with Scott as Scott does a quarterly report out on kind of the changes in the industry. Scott brought along with him Carter. Carter is the senior consultant for data and analytics at Trella Health. I've known Carter for a long time. He's one of the smartest kids around data in the industry, probably knows the CMS data better than anybody. So super happy to have both of these gentlemen with me today. Welcome to the show, guys.
Thanks, Tom. Good to see you. Okay, now let's be clear. So Carter is a data scientist at heart. And here's a guy that takes our tens of billions of claims, Medicare claims, commercial claims, payer rates, and everything else, and studies this stuff to see, okay, what are some unique things that are happening in the market? So when I think about for myself, Carter's the guy who brings things like, hey, Scott, you got to see what trend we're seeing on this and what trend we're seeing on this. So it's great to have him join us as an expert. I cannot do anything close to what he can do when it comes to understanding the data analytics and the science behind it. So I'm super happy we got him here.
Yeah. So most of our listeners are Trella customers. And so we're going to do this on a quarterly basis to really deep dive into the data and let these experts talk about what's going on in the data. So big news came out this last week from Trella. So Scott, give us the big news. What did you guys change that was kind of ground shaking?
We've got all kinds of big news, it seems these days, but AI is coming out in our product this quarter. I don't know if that's a Ask Trella prompt. Carter's got a big one. Carter, what CMS has made a big change? Tell us what's going on there. I know aside from AI and all the things we're doing there, what's coming up with CMS?
Yeah, so Trello, we recently got approved to have access to monthly data that is being released in the data warehouse called the VRDC, Virtual Research Data Center, that houses all of the Medicare fee-for-service and some older Medicare Advantage claims that we use to populate all of the data shown in MarketScape Insights. And we've now gotten access to look at getting monthly claims data rather than what is previously quarterly. So hopefully we'll be able to transition that into faster turnarounds between when we get the claims data and then what the claims data is the recency of the claims that are shown in the actual MarketScape Insights product. So super exciting to be able to get the data as fast as possible, which makes the insights as relevant as possible that you can get from the MarketScape Insights.
We combine tens of billions of claims data with billions of commercial data as well that we acquire and aggregate, as well as payer rate data and a lot of stuff. A lot of our data we actually get monthly, and sometimes real time data with our EHR integrations and others. But CMS data has historically been quarterly, and we therefore kind of slow down the process as we combine all that data. And what's so exciting for the data science team and our business and for our customers is we're now going to be able to take the monthly data we already have, combined with CMS's monthly data, and start to publish and roll out monthly data, which would be pretty cool.
Rather than having these major, huge data releases once a quarter, there's going to be smaller incremental monthly data releases. It's going to be able to provide insights that are more timely and they're more kind of drip fed rather than everything in the quarter all at once. So it's a really good benefit. It also helps the data science team because it's less data to go through and analyze and aggregate up every single monthly release. So that difference in volume makes it a little bit easier to go streamline the process from getting data from our vendor and the virtual research data center into the product.
And we can't forget that the home health and hospice agencies have to submit their claims data too. And so they're a little bit of lag as well. So they haven't completed the episode yet. They need 10, 15 days to collect all the orders, do all those things. Then they get their final claim, and that's the data that you're getting in the VRBC. So there's a lag from that as well. So
Yes.
that's probably slowing you guys down a little bit too. Good. That's awesome though. I mean, it's a big change.
Yeah. It's the benefit of one thing that's really nice about the VRDC is that they are finalized claims and it's, 100% coverage, which is a huge benefit, especially when you're looking at third-party vendors. Their claims, some of them may not be finalized, but that benefit of having the finalized claims, there's a con that is associated with that, which is the claims need a little bit more time in order to be finalized before we're able to actually access them and analyze them and get them into the product.
Okay, so CMS just announced there's a moratorium on new home health and hospice licenses. And I know you guys have been looking at a lot of these provider numbers. What are you seeing in the data, Scott? And we'll start with you, and then you can flip it over to Carter. What are you guys seeing in the data as it relates to the growth of home health or the growth of hospice?
Okay, so two things. If you think about just core macro level stuff, we know that the home care market and home health market is about $162 billion market in 2024, projected to grow to over $380 billion in 2023. I mean, massive growth. And we know all the reasons behind it, population and the tailwinds associated with it. And interestingly, in that market, just I'll mention because it's something I'm always interested in, the home infusion part of the business. Home infusion is a big market for us as well. We serve home infusion with HIPAA codes and a lot of different things so they can grow their business. We're seeing a market going from $20 billion to over $40 billion. But more importantly, within home health, we're seeing a 14% increase in infusion, which is also fascinating. So more and more people are getting care at the home and infusion at the home, which is something that's exciting. Now, one of the things that Carter showed us in the last few weeks that I thought was really interesting, from 2019 to 2023, if you look at all the counties in the country, we saw in 94% of those counties in the United States, we saw a reduction in home health agencies. 94% of every county in this country had a reduction in provider care and home health. Fewer providers providing care. So, Carter, help us understand, do I have this data right? What does it mean in your minds and what's going on in the market? And then Tom, I love your opinion. You talk about the moratorium happened. People are now not opening new home health agencies, hospice agencies, and you're seeing a decrease in counties already. What happens?
Yeah, a couple of points I want to address there. So yes, it was absolutely described correctly. And those are between 2019 and 2023, 94% of the counties in the United States saw a decrease in the number of home health agencies. That's defined as a unique NPI number that was able to take care of Medicare fee-for-service. I think there are a couple of reasons for that kind of trend. The first of which is the time frame encompassed 2020 and 2021. That was a very tumultuous time for home health agencies. So I'm almost positive that some of that decrease was due to the tumultuousness and struggles that home health agencies had amidst the pandemic. I think another major factor leading to that decrease is the amount of mergers and acquisitions that are occurring. Obviously, there are a couple of very large, high-profile mergers that have occurred over the last couple of years. But I think one of the major drivers of these decreases are the smaller, more localized home health agencies being bought out and purchased by either similarly sized or some of these larger enterprise-level home health and hospice agencies. One thing that I do want to kind of switching gears here to answer your question about the moratorium, the 6-month moratorium on new home health and hospice agencies. One thing that we've actually been able to publish, and I think it was published as recently as today, if not maybe yesterday, is we published a tool that allows users to look at a map of all of the counties in the United States and look at the number of new home health and hospice NPIs that were registered in each of those counties. It's a really interesting look because you can select the line of business, home health or hospice. You can select the coverage. So there's the NPIs. They can be enumerated just basically by saying NPES, which has the National NPI Registry. An NPI can be enumerated where it appears in this NPES database. That doesn't necessarily mean that they're able to bill commercial payers or Medicare. So I can go through the kind of logistical hoops and say, hey, I'm a home health agency. I want an NPI number. NPES will give me that NPI number. However, I need to go through the Medicare CMS certification process to actually be able to bill Medicare for any of the home health services that I provide. So this tool is able to look at both the enumerated, the number of new NPIs, and the number of actually Medicare billable, like the number of new NPIs that are able to bill Medicare as well. So those two different views make it really worthwhile. I think in terms of some of the stuff that you're seeing in the data, there are a couple of things that you immediately expect to see. So, for example, beginning in January of 2020, so between January 2020 and January of 2026, there were 2,200 and one hospice NPIs that were enumerated in Los Angeles County. I think it's surprising that number is so high, but I think that's kind of explains some of CMS's immediate kind of crackdowns specifically located in Los Angeles County. In fact, of those 2,200, 453 of those new hospices were actually able to bill Medicare. So it's not just, people saying, hey, I'm a hospice agency, but not getting Medicare certified. A fourth of them, the new agencies that appeared in LA County, are able to bill, or were able to bill Medicare prior to the CMS fraud crackdown. There are a couple of other counties that I think are interesting that I want to point out. The first of which is Clark County in Nevada, which also, it's the second highest. That doesn't mean that it's nowhere near in the same ballpark as Los Angeles County. But there's kind of three counties that I want to talk about in a little bit more detail. The first one is Clark County, Nevada. The second one is Franklin County, Ohio. And the third is Miami-Dade County in Florida. So these, the top county in terms of new agencies is Los Angeles, but the next three are those three counties: Clark County, Franklin County, and Miami-Dade. I would not be surprised if some of those counties saw a similar kind of crackdown investigation, a formal investigation into some of those new agencies that were enumerated and got Medicare certified over the last couple of years by CMS.
Yeah. Hey, Carter, on this new map that you have, which, by the way, I haven't seen yet, but I'm sure you're going to demo it to me. Does it have the actual change of ownership, the CHOW date in that map?
It doesn't contain, it's not looking at a change of ownership. So if an NPI, let's just say an NPI was purchased by another parent organization, that doesn't count. It's not being counted as sort of like a new agency. That NPI just is the same. And if they, maintain their Medicare certification and everything like that, it's just counted as like that one single new agency. So it doesn't contain the change of ownership information.
So as a guy that uses this data every day to help with acquisitions and help customers figure out where they want to do de novos versus acquisitions, the government's shutting off the de novo model, essentially saying you can't go create new agencies unless you already have your application in. And there's all these rules around that. So now it's, if I want to grow my business, which, by the way, if I'm, a publicly traded, private equity backed, not-for-profit that wants to continue to grow, I either have to go deeper in my provider numbers, so I have to get more volume out of the provider numbers that I have, or I got to do acquisitions. And then when you do acquisitions, now the 36-month rule comes into play. So if it's been 36 months and the change of ownership for greater than 50%, then that goes into a different category. And so we're essentially going to take a box and put it around, or I'm going to take a box and circle all the agencies that are acquirable because of the 36-month rule. And if they're not acquirable today, when is that date going to hit? So that then you can go acquire them. And so I'm not the only smart guy in the world. Everybody that's in this business is going to do that. So super interesting that, that the rule happened. I think, a lot of people tell you it's a positive. We got to get the fraud out of the system. A lot of people tell you it's a negative if they wanted to grow, if they had a de novo strategy. I do think it's going to make home health and hospice agencies, think twice about whether they sell or not right now. I mean, it kind of, essentially what we really built was a national CON, right? I mean, if you can't grow and we're locked into these, you have a national CON. So you either have to do an acquisition or you got to figure out how to go deeper into your current provider numbers.
Yeah, that was actually a question that I had for you and Scott. If you, because like you said, it essentially is a certificate of need kind of like, that's run by state levels. But this moratorium is, nationally applicable. I'm curious if you think that the federal government or CMS or Dr. Oz are thinking about putting together a more federal certificate of need program for new enrollees kind of after this 6-month moratorium.
Yeah, there's been 3 rules that have come out, and I don't know them all right now off the top of my head. I was reading them this morning where they're, especially in the hospice space, they're really going to change what it takes in order to become a provider number. I mean, there's going to be fingerprinting involved. There's going to be, different kind of levels of surveys, annual surveys, quarterly surveys, monthly surveys, kind of things. So I don't think they're going to come out and say, hey, this is a certificate of need country. It's going to be, these are all the rules you're going to have to follow in order to get a provider number, because we got to get the fraud out of the system, right? We got to, people that are not seeing real patients, that are not providing real care, that's where the problem's at. And by the way, that's my tax dollars, that's your tax dollars, that's Scott's tax dollars, and he pays a lot. And so I think it's super interesting right now. I think 6 months is probably the beginning. My guess is they'll extend this out for a year or so until they figure out that they've solved the problem. So, if you're an agency out there that's, in a de novo strategy, you're going to change your strategy a little bit. But I don't think it's going to keep you from growing. I think it's going to put all the good actors in circles together and allow people to continue to provide great care to the nanas and papas. I am a little worried about the 94% of the counties have decreased the provider numbers. I do know that in a lot of these counties, a lot of the states, if you have a provider number and, you're in Amarillo, Texas, you can service the counties around Amarillo too, and that wouldn't recognize in your data because you're only looking at where the provider number's at. So there's still probably care being provided around those counties, but we're forcing nurses, social workers, aides, chaplains, all these people to drive a lot farther because we can't put a provider number in there. And so, if it restricts access to care, we got a problem.
Now, I'm kind of curious. So, if like paint the end of that picture just for a second. So, you've got fewer NPIs, I get, and there's probably just consolidation, and sure, other people can care, and I'm sure the consolidation has a lot to do with it. I'm sure that some of the smaller guys are going out of business, and if some of them are bad actors, then good, right? And you've got this moratorium, no new for a while. In your mind, is access to care being impacted at all? Do we think it's impacting, you know, getting care? Do we think it's going to and reduce adherence? Do we think if any of that's going to happen in your mind?
I do think so, and I'm seeing it. I've seen it in a couple of scenarios where people have called me and said, "Hey, can you use your Trella Magic and go find me a home health provider in the middle of New York, not New York City, but in the middle of New York, and on upstate New York." And we there was one provider, and that provider couldn't take any more patients; they were completely blocked. And so this guy's dad, who's a friend of mine, his dad can't get to care, and it's 62 miles to the next hospital facility from where he lives. He's in the middle of nowhere, New York, there's nobody that can take care of him. So what does he have to do? Luckily the guy has a little bit of cash in his pocket. He has to go find a nurse, hire the nurse, and essentially provide private duty care for his dad because he needs care. He's got some falls problems. He's got some, a lot of other things going on. He needs care. And the only way to do that is to go, private pay somebody to take care of him. So that's one small scenario, but I guarantee you those scenarios are all over this country. And so we have people that are going back in the hospital and getting more aggressive treatments and all those kind of things when they should be on home health and in their home, but they can't get care. So absolutely, I think it's going to happen. I also think that this buzz in the industry around home health and hospice and the fraud and the moratorium and all that, I mean, we're on national news every single day. And I'm sorry, I don't watch the national news, but I know it's out there. But the seniors watch the national news. They sit and watch the news. They watch, whether it's Fox or CNN or one of those. And so the buzz is in there. And so I've talked to a few seniors, including my own family, who said, I don't want to be on home health. That's just a bunch of fraud. Well, that's terrible for our industry. And so we have to think about that. Like, what's this message really looking like for the home health? The good providers out there are getting smeared with the bad providers. And it's unfortunate. Same thing in daycare, same thing in autism. I mean, Oz was talking about autism yesterday in Minnesota. It's out of control in Minnesota. And, they were there talking about that. Like, 1 out of 30 kids is getting diagnosed with autism, and they're spending millions of dollars on these kids. And it's all fraud. It's terrible.
Scott, to your question around whether or not the moratorium and then the moratorium on new home health and hospice agencies, whether or not that will impact adherence, I wouldn't be surprised if it does. But I'm going to be interested, we're not going to be able to know that until for another year or so until we get the actual data. I can say that, right now, adherence to home health discharge instructions is on a small but consistent upward trajectory, especially since the pandemic. So in 2020, the adherence to inpatient for fee-for-service patients, the adherence to inpatient discharge instructions to home health was about 69.2%, compared to in 2024 calendar year, that adherence number is 71.1%. So there's consistent annual small increases, but with this moratorium, it's in the impact on the access of care, especially for some of the more rural communities. I would not be surprised if that either the trend changed to either stay flat or even decreased.
Do you look at that data based on Medicare's classification of a county being rural or not?
No, we do not look at the adherence. That'd be a really interesting thing to look at, though.
It'd be really interesting because the government classifies you as rural or urban, and then what is the adherence rate to rural or urban in those models would be really interesting.
Carter's taking notes. He's going to be ready for the next episode. I think one of the other things, Tom, that we were talking about, I think you wanted to ask me about earlier was if you think about home health in general, what I think is awesome to hear is we're seeing the performance story look really good. Carter and the team was sharing some data around how home health is rising to the challenge. Agencies are handling more clinically complex patients while holding or improving readmission rates. And we're seeing it as a big improvement or an improvement. So patients are sick or going to the home, and home health agencies are able to take care of them better than they were in the past, which is a great story. Carter, what are some of the stats you're seeing on this? And I'd love Tom's feedback on how he sees maybe home health agencies performing better internally, what they're doing clinically to improve, to try to understand this.
Yeah. So in order to analyze or get an understanding for, patient complexity, one tool that we have is the average risk score. The average risk score for across all Medicare beneficiaries is set to be, the average is 1. So if you take the average of the risk score and it's assigned to each individual Medicare beneficiary, if you take the average of the risk scores for all of those across all fee-for-service beneficiaries, you'll get a value of 1. And really, it's a proxy for patient complexity, but the primary driver of that metric is the estimated amount that CMS thinks it will have to spend in order to provide healthcare for that beneficiary in the next year. So again, it's a little bit of a blunt object when you're looking at when you're trying to analyze or understand trends in patient complexity, but it is a useful tool. Because now, one thing I always say when I'm looking at these numbers, when you're looking at the average risk score for home health patients, so any Medicare beneficiary that was admitted to a home health, because it's such a small number and because it has a value of 1, there are seemingly, from a numeric baseline absolute value standpoint, there's small changes actually mean a big deal when it comes to what the home health agencies are actually seeing on the ground. So, for example, I looked at comparing 2021 and 2024 home health data, and the average risk score for home health agencies increased from 2.3 to 2.5. So again, it's just a 0.2 increase, but that is a massive indication that the clinical complexity of the patients that they're seeing across that time period overall as a whole for the home health industry increased quite a bit. Because you're going to be saying, okay, their home health agencies, in order for the average to get pulled up, they're going to be treating patients with a average risk score 3s, 4s, 5s, which is more commonly associated with patients that would be taken care of either by a hospital or a skilled nursing facility. So I think to answer your question, that small increase in average risk score indicates that home health agencies are treating much more clinically complex patients. But that also coincides with basically almost no change or even a reduction in some of the key quality outcomes. So for example, across that same time period between 2021 and 2024, there is actually a decrease in the readmission rate from 11.9% to 11.8%. Again, that doesn't sound like a massive decrease, but when we're talking about the almost 3.5 million fee-for-service admissions to home health agencies in a year, that 0.1% reduction in readmission rate, that's huge from a financial and value-based care perspective.
For sure.
Does that make sense? I feel like that was really long-winded.
No, it does. It does make sense, though. It absolutely makes sense, and I think we're seeing that. I think you're seeing, like, if you're on the ground, you're talking to salespeople and agencies that are receptive patients. People are getting pushed out of the hospital a lot quicker than they used to. I think about my mom who had a hip replacement surgery. She went in at 3:00 on a Friday and got discharged on Saturday morning, and literally was, less in the hospital less than 12 hours. Now 2 days because it's the over midnight rule, so they get paid for 2 days. But used to if you had hip replacement surgery, you're in the hospital for, weeks, 2 weeks, 3 weeks, and then you went to outpatient rehab and all that. So I think we figured out that people want to be in the home, they want to get discharged quicker. The other thing I think is going on right now is home health's trying to figure out, and we do this with Tango in our Tango relationship, is we want to get these patients admitted as fast as we can when they get out of the hospital. And home health agencies are doing a really good job of that now. They're pushing as hard and fast as they can to get to that Nana's house. They want to beat that, the transportation to Nana's house. I want to be there when she gets there. Does she need a walker? Does she need handlebars? Does she need, a different kind of bed? What kind of DME, oxygen, whatever it is? I want to be there when Nana gets home. Used to discharge, and 2 or 3 days later, we would show up with home health after she got settled in. And so I think that's the phenomenon, the trend that's there.
Yeah, and actually that bears out in the data that I've seen. So I was looking at, again, kind of looking at the same time period between 2021 and 2024, the average time to start of care. So this would looking at discharge from an inpatient setting, number of days between discharge and then admission to the home health agency. In 2021, that value was 4.8, so 4.8 days. In 2024, it reduced by over a day and a half to 3.12. So that's a massive decrease in the average time to start of care that it seems like is the data bears out exactly what you're kind of seeing on the ground and your inclinations on the ground.
Yeah, for sure. That's awesome. All right, Scott, let's jump over to team. So you guys are doing something called team, and every industry has a team, but it's really special to what you're doing at team. So explain that to the audience and let's talk more about it.
Well, this is really, the team model that CMS released, and 740 hospitals have to adhere to this model. It's tied to taking risk for 5 critical episodes. If you think about lower extremity joint replacement, surgical hip and femur refraction treatment, spinal fusion, CABG, and major bowel procedures, these hospitals have been voluntarily put into this model where they're financially accountable for not just the procedure, but for the next 30 days of care post-discharge. So it's it's another value-based care model that they've released. It's out in the market since the beginning of this year. You can see the participants and data that we have, for instance, in our product. So what's happening is our customers are looking at, especially the post-acute providers, they're trying to look at the hospitals that are participating in team and those 5 critical episodes, and making sure that based on the DRGs associated with them, they look at their performance compared to others. So the hospitals want to partner with great post-acute providers that have good outcomes in those specific DRGs. And for our post-acute customers, we want them to see the competitive nature of how they compare in those DRGs to quality, so that they can focus on quality outcomes related to that. Again, participating with the hospital. It's an interesting problem. And Carter, when we look at this I think you have some pretty good topics or numbers on this. When you think about it, it's about a $10 billion stake Medicare reimbursement just across 3 of the 5 team episodes. Tell us how you see it from a numbers perspective and stats.
Yeah, I've got a lot of numbers that I want to talk about. So there are 724 participating hospitals. Some of them opted in. So participation was mandatory for some. Some hospitals, they weren't They didn't have to participate, but they opted in to begin participating in it. The team model in 2026, there are kind of a couple of different tracks. In 2026, there's kind of only upside. So basically, the way that hospitals are going to be reimbursed is that for base cost and then 30 days of follow up, this is how much we're going to be, providing for. This is how much we're going to pay for it. Anything above that, you're not going to eat. You're still going to be reimbursed for it in 2026. But if you come in under, there's a potential for up to a 10% upside. So let's just say for one of the, for example, a patient, their target for a lower extremity joint replacement is $30,000. Well, if they are able to get the reimbursement for that patient down to $27,000, they can keep that $3,000. When it comes to the next track in 2027, this is where a little bit of risk begins to be introduced. So it's either and it's capped at either a 5% upside or a 5% downside. So that patient, if they were able to save, it costs $27,000 instead of $30,000, they'd only get $1,500, an additional reimbursement. However, if it ends up costing $33,000 to treat a patient, then they'd be on the hook for $1,500. So it's a really interesting follow-up. I have a couple of thoughts on one, why these categories were selected, and two, what's the primary intent for CMS in releasing this model? So first, kind of to get some baseline stats, we have historical data it's really clean and easy to analyze for 3 of the categories. And those 3 categories alone add up to over across the entire country. So this is not just team participating hospitals, but all hospitals in the country. It's about, for just 3 of the categories, it's about $11.8 billion annually.
Wow.
So when this probably gets implemented countrywide sometime in the 2030s, 2031, 2032, depending on how this team model goes over the next 4 or 5 years. It's going to be a big deal. It's going to impact a lot of hospitals. Across all of the team pet categories, there's actually, one of the reasons I think that these categories were selected is that over about 11% of annual fee-for-service inpatient episodes are related to a DRG in one of these 5 team categories. So it's kind of a way I think they selected some of these categories because, one, it's a non-insignificant portion of the fee-for-service reimbursements that they have to inpatient settings. And I think another reason is that there's a fairly wide range in how much in both base costs and follow-up costs are associated with these DRG categories. So for the 3 categories that I looked at, when we're looking at the kind of the 5th percentile and the 95th percentile, for major bowel, for instance, there's almost a $21,000 difference between those 2 percentiles for how much just the base cost of a major bowel procedure is. Right? That's a fairly large variance. When you're looking at hip and femur, it's around $14,500. And for CABG procedures, just the base cost, there's a wide range of about $36,000. So I think that variation across the country where, some hospitals are able to do a CABG procedure for $16,000 while others are charging $68,000. I think it's a way for CMS to kind of address that significant variability in reimbursements. Obviously, there's going to be some geographic differentiation. New York City is more expensive, famously, than anywhere else in the country. So there's some variation is expected. But when the variation is that high, where it's, almost twice what the actual, base reimbursement or the average reimbursement is, it's a way for CMS trying to rein in some of the high variability in the costs.
Carter, can I stop? Can I interrupt you just for a second? I think, Tom, when we're talking about home health, performance and quality and performance and improvements, 39% of team DRGs are instructed to adhere to post-acute settings, to some sort of aftercare and post-acute. and only 39.2%, if I get that right, based on Carter's data. But here's the thing that was interesting to me. Adherence to home health discharge instructions for lower extremity joint replacement and CABG categories is strongly correlated with reduced inpatient average length of stay. So if you're able to get patients if you can increase that 39% and you can get patients into post-acute, you're going to see a reduction in average length of stay, which is going to help on the episode as well from time to staying in the hospital, which is great. And hopefully getting post-acute care more quickly and having a better impact, especially if you're matching quality DRGs.
What does that mean to our listeners? So the listener that has a great relationship with the hospital that has a great relationship with the post-acute care, who can agree or can figure out how to admit that patient quicker, faster, better, and follow the protocols which the hospital has done, they're going to reduce the amount of money that it's going to cost to spend on that patient. They're going to make the hospital happier. It's going to make the home health happier. And so if I'm advising a home health agency, you need to go figure out who's working in the team program. So these 700 providers or hospitals. So who's in the team program, build a team program around so that like protocols and, quality measures and reporting back, and go sit down with the CFO and the CEO of that hospital. And whether you have a joint venture with them or you're just, a referral partner with them, and make sure that you're following these guidelines and these rules to help them, benefit from the team, value-based care models that are out there, especially this year, next year, and going forward. And then if this becomes a national program, as Carter said, it's going to become a requirement. So I don't know that people are thinking about this a ton. And Scott, that's a great segue to add a little plug for the last visit first. If you have comments or topics that you want this group, me and Carter and Scott to talk about, man, put it in the comments. We'll do the research on it. We'll study it. I'm telling you, Carter's one of the smartest guys out there when it comes to not only just Medicare data, but Medicare Advantage, fee for service, everything. And so if there's topics like that you want us to cover every quarter when we sit down and meet, man, I'd love to hear those, because there's some stuff here in team that I'm going to take to my customers that are out there that are trying to figure out how to grow their home health agencies and how to be better partners with these hospitals. And they want this level of detail and data. So that's really cool. Thank you guys for bringing that up. With that being said, we're about at our time. Carter, is there anything else that you wanted to highlight of the data that you've been looking at?
I think I'm good.
Yeah, you've given a lot of good stats. You've given some really good stats.
Look, we have, as you know, Tom, we have so much data and so many insights, and we only have so much time. For folks like Carter, they want to dig into the data and they want to create insights and help others understand so that we can do really beneficial things for the community, for the providers, and ultimately for the patients, as we all have this dream of improving outcomes and for the patients at the end of the day. So I know we're going to keep digging all the time, every day, with our new monthly data, with all the other data that we analyze, including the real-time data we get from all the 30 plus EHRs in the post-acute side and the acute EHRs we integrate. All that data is now coming into our orchestration layer, and we're AI enabling all of it. So our insights are just going to be that much more powerful. So we look forward to bringing additional insights to you. If you have any more specifics, to your point, let us know. We'll do some data and some digging. And at the same time, we're going to be looking at things that are on people's minds and top topics, and we're going to be bringing it back to you.
Love it. Gentlemen, thank you for being here. Happy Memorial Day. Have a great weekend. Remember what Memorial Day is about, and it's great to see both of you. Thank you, Carter, for your advice and direction too.
Thanks for having me.
Thanks, guys. Take care.